It worked fantastically for me. There was very little pain after the operation as well. Recovery was extremely quick.
I was in the hospital for overnight, went home the next day, walked with a walker for a day or so, and was completely mobile at the end of a week.
I was real happy that I was able to leave the hospital right away, the next day actually. It was just a good feeling to know that I didn't have to stay longer, or as I had heard, some people would have to go to rehab after surgery. I didn't have to worry about any of that.
I haven't had one complication from the surgery. It just seems like I progressed so fast, and the pain is gone. It's like I never had the operation at this point.
Developed as an alternative to traditional total hip replacement, the Superpath hip technique is a tissue-sparing approach intended to get patients back on their feet within days instead of weeks or months. Patients who have undergone this operation are generally able to walk unassisted or with single-sided support on day one. Superpath is a patented technique that allows the total hip procedure to be performed without dislocating the femur. By avoiding the traditional cutting of 4 to 5 tendons around the hip, there is typically less trauma and therefore less pain, less bleeding, and more tissue left intact when compared to traditional hip surgery. In addition, the Superpath technique permits proper cutting of the femoral neck and discourages the chance of femoral fracture during implantation of the stem. The key to any successful tissue-sparing approach is the avoidance of trauma to the soft tissue structures around the hip. The Superpath hip technique offers a tissue-sparing approach that does not require the cutting of any muscles. This allows the average Superpath patient to leave the hospital in as little as 2 days after surgery and without the typical hip bending restrictions associated with traditional total hip replacement.
I really would highly recommend to anybody who is having hip problems to go this route. It is so much less invasive than the other procedure, and it enables you to do so many things very quickly. If I had it go over again, I would do it in a minute.
I had surgery on Thursday and I walked on Sunday, so 3 days from the point of surgery I put my cane in the corner and started walking on my own.
Well, I've talked to other people who have had hip surgery, and I've seen their recovery period, which has been rather long. And I am absolutely amazed that it's been just almost exactly a month since my surgery, and I'm walking without the assistance of a cane. I'm able to walk with my neighbor. I'm able to ride my bike. I can walk my dog. There isn't too much that I'm not able to do right now.
My surgeon told me to do, Dr. Grandick told me to do what I felt comfortable doing. I was really surprised because I have some good friends that are physical therapists, and they were just blown away by that. I can walk, I can go up steps, I can do this, and I can get in and out of the dryer, and they're like, oh wow.
The patient is placed on his or her side on the operating table, with the leg that is to be operated on bent 45 degrees. The surgical incision starts at the top of the femur and extends 2.5 to 3 inches above this point. The gluteus minimus muscle is moved forward, while the external rotator muscles are moved rearward, allowing excellent access to the hip joint without cutting the soft tissues. The femur is prepared according to the design of the stem implant, and the final femoral instrument is used to make an accurate neck cut and remove the femoral head. Using an alignment instrument for proper implant positioning, a tube is inserted to allow preparation of the acetabulum and implantation of the cup. The acetabular cup implant is positioned using the alignment instrument and impacted through the tube. After positioning the cup liner and femoral head implant, the stem implant is firmly impacted. The leg is then raised to join the femoral neck and femoral head implants and complete the procedure.
Well, I think I got out of surgery about 11 o'clock, and at 3 o'clock was the first time that I walked, which was pretty amazing.
I felt I made the right decision in choosing Superpath. almost immediately. When I saw the size of the scar and I saw that I was walking that same day and I was walking the halls the next day, I was very happy I went that route.
In the end, I only missed 2 days of work from a total hip replacement. I missed work on Thursday and Friday, had the weekend to recover, and by Monday I was ready to go.
I think the Superpath technique was the most positive thing that ever happened to me.
Superpath Micro-Posterior Approach. Minimal trauma and therefore minimal pain and minimal bleeding as compared to traditional hip surgery. Talk to your doctor and see if this innovative hip replacement procedure is right for you. Hip systems manufactured by Microport Orthopedics are designed to relieve hip pain and improve hip function by replacing the parts of your hip that have been severely damaged by degenerative joint diseases. You should not receive a Microport Orthopedics hip system if you have an infection of the body or blood. Your bones are not yet fully grown. Your bones are not strong enough or healthy enough because you have severe bone loss, osteoporosis, or have a family history of severe bone loss. You have any blood vessel-related disease, muscle-related disease, or nerve and muscle-related disease that may prevent the artificial hip joint device from remaining stable or that may prevent you from following instructions during the recovery period. You have a suppressed immune system due to diseases such as AIDS, or are receiving high doses of corticosteroids, or you are severely overweight. As with any major surgical procedure, there are risks and recovery times. Potential adverse effects which may result from hip replacement include, but are not limited to, the following: pain, bone or component fracture, blood vessel damage or blockage, temporary or permanent nerve damage, a sudden drop in blood pressure during surgery due to the use of bone cement, leg deformity, blood clots that can travel to your heart or lungs, delayed wound healing, and deep wound infection or accelerated wear of the prosthesis, which may necessitate additional surgery. Your weight, age, and medical history determine your specific risks. You should ask your doctor to explain all of the risks of surgery to you and what type of rehabilitation you can expect. Your doctor may request that you attend physical therapy. Your doctor may also give you additional signs and symptoms for which to be aware. Hip replacement implants cannot be expected to perform as well as your natural joint and carry the risks of breakage and wear, particularly if you lead a very active lifestyle or place a lot of demand on the implant. The results described in this video are specific to these individuals. You should tell your doctor about your full medical history, occupation, and lifestyle, or if you think you might have a hard time following any instructions you are given regarding your hip replacement. If the implant does break or wear out, you may need additional surgery.
These results are specific to this individual only. Individual results and activity levels after surgery vary and depend on many factors including age, weight, and prior activity level. There are risks and recovery times associated with surgery, and there are certain individuals who should not undergo surgery. Only a physician can tell you if this product and associated procedure are right for you and your unique circumstances. Please consult with a physician for complete information regarding benefits, risks, and possible outcomes.
About 3 years ago, I was playing golf in Dallas, and I hit a shot, and there was a pain in my left hip that sent me straight to my knees. Relocated to the Memphis area and started doing P90X. And doing P90X, I really started to do some damage. I started to look into my different options. And if anything, if you take anything away from my story, it's that I know a lot about my options when it comes to a hip replacement. And I probably overanalyzed this decision as far as what I was going to do, when I was going to do it. You know, I put it off thinking, you know, I can get through this. You know, everybody at work had an opinion. All the doctors that I work with had opinions. I had a million different opinions in my head as to what I should or should not do. What products, what surgeon, you know, what surgical procedure. And, you know, after all of that, I came to the conclusion that I wanted to go talk to Dr. William Kurtz in Nashville about doing a Superpath. And the more I learned about Superpath, the more I realized, I need to really get to know this well. And, this may be the route I need to go, but I really need to make sure I understand the surgical procedure and really what the recovery looks like. Part of why I've been in denial and put this off is I did not want to have to go through the recovery. My dad had a hip replacement. My hip problems are genetic arthritis. I inherited it basically from my dad. He went through the same thing. I watched him go through a normal posterior total hip, and he had a really tough time recovering. And that was the last thing I want to do right now. I'm extremely busy with work. I can't afford to be out for 2 months, recovering from a hip surgery. So when I started talking, even Dr. Kurtz was like, yeah, you can walk that afternoon, of the surgery. Have surgery that morning, I want you to walk that afternoon. What gave me the courage to go ahead and get this surgery done now was Superpath. Bottom line, knowing that, it's so much less invasive, it gave me the courage to say, it's time to go get this done. And I think as more and more patients, get the word out there that they can have this type of recovery versus going through what my dad went through, then they'd be crazy not to demand this from their surgeons. People are saying, are you ready? Are you ready for surgery? And I'm like, absolutely. You get to a point when you need a hip replacement that you're in so much pain all the time and you can barely do anything day to day. It's hard for me to put my shoes and socks on. So yes, when you get to that point, you can't wait to have surgery. And then if you know that the surgery is not going to be as bad as what people used to have to go through, and you can have a Superpath and recover this quickly, I'm ready tomorrow. It's about 6 o'clock in the morning, and they're about to take me back. My surgery is at 7:30 this morning. The thought is that with Superpath, I'll be walking as soon as noon, so 12:30, hopefully I'll be walking. The biggest question I've had over the last 2 days is, are you nervous? I have to admit, the fact that I'm having Superpath and I've got Dr. Kurtz, I'm pretty relaxed. These guys are saying, hey, you seem pretty relaxed. I actually am. It's amazing what this surgery does for the patient. I think that's why I'm here talking to you guys now, is people need to understand the difference between getting a regular hip replacement versus getting a Superpath. It's life-changing. I should be seeing you guys in about 5 hours walking with my new hip. So I'll see you all then. Thanks. Okay, so we are 3 months out from surgery, and I wanted to run through a timeline of how well my recovery went. And up front, I have to say, I'm amazed at how easy the recovery was and how great I feel today. I mean, it's truly been life-changing. I've got my quality of life back, and I'm extremely excited to share with you guys, exactly what happened from the point I had surgery. So at 4 hours after surgery, I walked in the hospital with a walker, and it was hospital policy that I had to have the walker. They had to have a nurse standing next to me. The next day, 7 a.m., bright and early, I got up and I walked with a cane. So I didn't have to use the walker. They let me use a cane the next day. And again, I felt like I could walk without the cane, and I felt great the next morning. I had surgery on Thursday, and I walked on Sunday. So 3 days from the point of surgery, I put my cane in the corner and started walking on my own. Saturday night, I took one of my painkillers before I went to bed, got a good night's sleep. And on Sunday, I never took another pain med, and I never took any more pain meds from that point on. So I was only on pain medication for 2.5 days. On Monday, I was no longer on pain meds. I'm walking around the house. I was bored, so I was like, what the heck, I'm gonna go ahead and work. And I worked from the house that day, and I made phone calls, got on email. but I felt completely fine. And so in the end, I only missed 2 days of work from a total hip replacement. I missed work on Thursday and Friday, had the weekend to recover, and by Monday I was ready to go. And so it's just a testimony to, how great Superpath is for the patient. I mean, the fact that you can recover that quickly and only miss 2 days of work, I couldn't be more excited, because that was the main reason I was hesitant to even take the surgery, was worried about how much time I was going to miss from work.
Our family really noticed a quality of life change. Steve just couldn't do basic things like taking our dog on a walk around the block. He couldn't go jog with me anymore. And he just limped all the time and was in lots of pain and complained about it through the night. And it was just hard to watch him go through that process. He couldn't enjoy golfing. His golf game was getting worse. He couldn't do a lot of the fun activities that we all do together. So you feel like you're sitting on the sidelines of life. The recovery process with Superpath was amazing. It was such a rewarding experience, because I thought we would be in the hospital for at least 2 nights. We were out after the first night, driving home, and by the end of the weekend, Steve was walking up and down the stairs. We did not think he would be able to do that. Steve's quality of life is so much better, and we have Superpaths to thank for that.
These results are specific to this individual only. Individual results and activity levels after surgery vary and depend on many factors, including age, weight, and prior activity level.
Well, I like to go do a lot of hiking and walking, because I have 2 dogs. I like to take them for a nice long walk. And I also like to golf. I'm pretty active. I go to the gym. Pain first started when it was pretty mild. I didn't pay too much attention to it because I could tolerate the pain. However, as time passed, I noticed that the pain was increasing. After a month and a half or 2, I realized that this is something that it's not normal. I could barely walk without stopping for a moment to relax. I could not walk my dogs because they were hurting me when I was walking 2 of them. And when I tried to golf, that was just next to impossible. I just couldn't do it. When I went to see Dr. Chada, he had authorized me to go get an MRI, and the MRI result indicated that I had avascular necrosis, and he could understand why I was going through all that pain, and he suggested that I should have a hip replacement. I learned about the Superpath from Dr. Chada when I saw him the second time after the MRI result showed, and he was going to explain to me about the hip replacement. He gave me the 2 types of hip replacement. One was the traditional hip replacement and what to anticipate with that, and then the Superpath with a minimal time of recovery, avoiding cutting the muscles, and he educated me on how quickly the recovery was, and that's why I chose the Superpath. When I had my left hip replaced and I was in the recovery room, I was up within 4 hours walking with no help at all, and I realized that I was pain-free, and that's remarkable. I was so happy to find out that within 23 hours I was going to go home, and I never anticipated that quick response of recovery that I had. I was so happy to be in my own home, in my own bed, about a month and a half or 2 months after my surgery, after my therapy. I felt like I could go do anything I wanted to. It took a year and a half after my left hip was replaced that I realized I was going through the same pains on my right hip. Since I already went through this the first time and realizing what the pains were, I immediately consulted Dr. Chada, and we had an MRI performed, and we discovered that the right hip was now being affected by the same avascular necrosis. When I had the right hip replaced, I anticipated the same amount of recovery time, but to my amazement, within an hour after surgery, I was able to walk unassisted to the bathroom. And as the day progressed, Dr. Chada felt there was no reason for me to stay for a longer period of time, so I went in the morning at 8 o'clock, and by 5 o'clock I was already at home. And that is incredible. I feel extremely wonderful. I feel great that I can do all the things I want to do, like golfing regularly, working out at the gym, hiking, walking my dogs, and any other things that I can possibly do to have fun.
There are risks and recovery times associated with surgery, and there are certain individuals who should not undergo surgery. Only a physician can tell you if this product and associated procedure are right for you and your unique circumstances. Please consult with a physician for complete information regarding benefits, risks, and possible outcomes.
The supracapsular percutaneously assisted total hip or Superpath arthroplasty is a patented approach that allows the femur to be prepared in situ and does not require dislocation of the hip. Unlike the direct anterior approach, the Superpath technique is also extensile and capitalizes on a surgeon's familiarity with the posterior approach, maintaining a better comfort level and allowing a phased approach to master the technique. By avoiding the traditional sacrifice of 4 to 5 tendons around the hip, there is less trauma, less pain, less bleeding, and more intact tissue, specifically the short external rotator tendons. In addition, preparation of the femur with the femoral neck intact discourages the chance of fracture associated with non-cemented femoral components and permits precise resection of the neck. The key to any successful tissue-sparing approach is the reduction in trauma incurred by the soft tissue structures around the hip. The Superpath hip technique offers a tissue-sparing approach that does not require the resection of any muscles and releases the piriformis tendon only when patient anatomy demands, which is repaired at the end of the procedure. The patient is secured in a lateral decubitus position on the operating table, preferably with the use of a pegboard and radiolucent pegs to permit a good quality intraoperative X-ray. With the pelvis leaning slightly posterior, flex the operative hip 45 degrees and internally rotate the operative leg 10 to 15 degrees to orient the greater trochanter upward. Resting the operative foot on a padded Mayo stand with the leg in slight adduction, the weight of the operative leg will bring the pelvis to the balanced neutral rotation. This is the home position of the technique, as the operative leg will remain there for most of the procedure. The incision is initiated at the posterior corner of the tip of the greater trochanter and extends 6 to 8 centimeters proximal in line with the femoral axis. The incision is carried down to the fascia overlying the gluteus maximus. The fascia is then incised using electrocautery in line with the main incision, and a pair of wing-tipped elevators may be used to longitudinally separate the muscle fibers with minimal trauma, exposing the bursa tissue along the posterior border of the gluteus medius. After careful incision of a very thin layer of the bursa tissue, a Cobb elevator is placed under the gluteus medius. The Cobb elevator is then replaced with a blunt Hohmann retractor, using gentle pressure to maintain the position in the interval between the gluteus medius and the gluteus minimus. With the hip abducted and externally rotated, a Cobb elevator is placed between the piriformis tendon and the gluteus minimus. The Cobb elevator is then replaced with a blunt Hohmann retractor, and the knee is lowered to return the leg to the home position. Gentle pressure is used to maintain the retractor's position between the posterior capsule and the external rotators. Should the piriformis tendon create excessive force against the retractor, it is then released at this time under direct visualization. A Cobb elevator is used to move the gluteus minimus anteriorly and expose the capsule. The capsule is then incised in line with the main incision using electrocautery. Electrocautery with a long tip should be used to incise in the trochanteric fossa to prevent bleeding around the base of the femoral neck. The capsulotomy is extended from the saddle of the femoral neck to 1 centimeter proximally over the acetabulum. The capsular attachment should be carefully peeled off the acetabular rim, extending 1 centimeter anteriorly and posteriorly. With the knee lifted to reduce external rotator tension, a Cobb elevator is placed between the posterior capsule and the posterior femoral neck. The Cobb elevator is then replaced with the blunt Hohmann retractor that was previously located at the posterior capsule, and the knee is lowered to return the leg to the home position. The anterior blunt Hohmann is repositioned similarly, and the capsule is tagged for identification during repair. With gentle adduction pressure applied to the knee, the femur is prepared with the head intact. The femoral canal is entered through the trochanteric fossa using a starter reamer. A conical reamer is then used to expand and lateralize the proximal opening. Depending upon the size of the templated stem, the round calcar punches are used to create a slot for broaching, progressing from the original reamer opening toward the acetabular rim. The calcar curette is then introduced into the femur to prepare the proximal medial portion of the canal, making sure the surface provides good cortical contact to promote bone on-growth while preventing subsidence and micromotion. The femoral canal is prepared according to the selected stem using either a ream and broach or broach-only technique. After sequential broaching, the final broach is left seated within the canal. With the knee lifted to place the leg in slight abduction, the femoral neck is resected across the top of the broach. An oscillating saw is used to cut through the neck, and a reciprocating saw is used to complete the cut anteriorly and posteriorly. A chance pin is placed in a solid portion of the femoral head, and the head is rotated into maximum adduction. A second chance pin is then placed in the femoral head and rotated into maximum adduction until the ligamentum teres is either torn or can be severed using electrocautery. Using the two drill chucks as handles, the resected head is removed. With the operative leg returned to the original patient position, acetabular preparation begins. Two spiked homins are placed at the anterior and posterior sides of the acetabulum into the axilla between the capsule and the labrum. The labrum is removed, as well as any remaining tissue from the acetabulum. A Zelpi retractor is placed subperiosteally at the acetabular margin at the proximal wound, and a Romanelli retractor is placed immediately distal. The combination of these retractors provides rotational stability and a surface on which to introduce reamers into the joint. The spiked homin retractors are removed. The tip of the bone hook is inserted into the broach to retract the femur anteriorly, and the alignment handle, portal placement guide, threaded cup adapter, and trial cup assembly are seated in the acetabulum. With the top of the alignment handle perpendicular to the patient's torso and the shaft tilted 10 to 15 degrees from vertical to account for the pelvic tilt of the patient on the table, the blunt trocar with cannula is inserted until the tip is resting against the operative leg. At the point where the blunt trocar intersects the leg, a 1 centimeter stab wound is made horizontally. The blunt trocar and cannula are then passed through the stab wound and behind the femur until they are visible through the main incision. The alignment handle assembly and blunt trocar are then removed, leaving the cannula in place. Acetabular reaming is carried out with sequentially sized reamers positioned into the main incision using the reamer basket holder. The reamer shaft, inserted through the cannula, engages each of the reamer baskets by way of a hex-shaped connection. The threaded cup adapter is threaded into the apical hole of the acetabular cup, and the assembly is seated on the alignment handle. With the acetabular cup in the acetabulum, the alignment handle is directly driven to medialize the cup. The cup impactor is inserted through the cannula and the tip of the alignment handle until seated in the dimple of the threaded cup adapter. The cup impactor is impacted until the cup is firmly seated. An alignment guide is available for attachment on the cup impactor. With the cup firmly seated, the threaded cup impactor is unscrewed from the acetabular cup using the hex tip of the cup impactor and removed using the reamer basket holder. Pilot holes for acetabular screws are created by inserting the drill tube through the cannula until it engages the screw hole. The screw drill is then passed through the long drill tube, and using the measurement markings on the end of the screw drill, drilling is carried out to the desired depth. The straight screwdriver is passed through the cannula to engage and tighten the acetabular screws. Head and neck trials are selected by measuring the resected femoral head or by preoperative templating. The trial neck is seated into the femoral broach, while the trial head is placed into the cup with the opening in a superior-posterior position. With the tip of the blunt trocar inserted into the top of the broach, the leg is translated to mate the trial neck into the trial head. Raising and lowering the foot of the operative leg assists in the maneuver. With the leg returned to the home position, the bone hook is inserted into the broach and lateral traction is applied. The blunt trocar is inserted into the hole of the trial neck, and the bone hook and blunt trocar are leveraged against each other to disassemble the trial neck from the brooch. After removing the brooch, the femoral stem and acetabular cup implants are impacted into position. The femoral head implant is placed into the cup with the opening in a superior-posterior position. The modular neck implant is then seated into the femoral stem and impacted firmly using the offset neck impactor. Should a pro-femur fixed neck stem be selected instead, it is now impacted into position. With the tip of the blunt trocar inserted into the top of the stem, the leg is translated to mate the femoral neck into the femoral head. Raising and lowering the foot of the operative leg again assists in this maneuver. Closure begins by approximating the joint capsule superiorly and inferiorly. The remainder of the incision is closed in standard fashion. Proper surgical procedures and techniques are the responsibility of the medical professional. The guidelines are furnished for informational purposes only. Each surgeon must evaluate the appropriateness of the procedures based on his or her personal medical training and experience. Prior to use of the system, the surgeon should refer to the Instructions for Use package insert and surgical technique for additional warnings, precautions, indications, contraindications, and adverse effects. Instructions for Use package inserts can be found under the link for prescribing information on Microport Orthopedics website at ortho.microport.com.
These results are specific to this individual only. Individual results and activity levels after surgery vary and depend on many factors including age, weight, and prior activity level. There are risks and recovery times associated with surgery, and there are certain individuals who should not undergo surgery. Only a physician can tell you if this product and associated procedure are right for you and your unique circumstances. Please consult with a physician for complete information regarding benefits, risks, and possible outcomes.
I had problems with an arthritic hip, and I went to see Dr. Olson, and he told me that the only solution to my problems was a hip replacement. Well, I continued to put it off for a while, and by the time I decided that I had to get it done completely, they had a new procedure, and we went ahead with that procedure, and I was in the hospital for overnight, went home the next day, walked with a walker for a day or so, and was completely mobile at the end of a week. It has enabled me to enjoy life once again. I went bowling, I golfed. I really would highly recommend anybody who is having hip problems to go this route. It is so much less invasive than the other procedure, and it enables you to do so many things very quickly. If I had it go over again, I would do it in a minute.